Then comes your nasal discharge. So nasal discharge, or rather any discharge, whenever you are speaking about a discharge from a human body, remember it can be a simple serous or watery discharge. Whether it let the anatomical structure be different. The discharge will be in the similar lines. It can be a watery discharge or a serous discharge. It can be a mucus discharge or a mucoid discharge. It can be a mucopurulent discharge, or sometimes it can be a frank pus where you call it as a purulent. Let the anatomical organ be different. You have to identify the proper disease condition where you will be seeing a watery discharge, serous discharge. There is a difference between this watery and serous discharge, or a blood-stained discharge, mucoid discharge, mucopurulent discharge, and a purulent. Almost all cases of nasal obstruction do present with nasal discharge and headache due to operation of nasal cycle. This is what you are supposed to remember as a golden take-home point. Almost all patients of nasal obstruction do present with a nasal discharge and headache. The variations how they present is different. And this nasal discharge can come out through your nasal cavity outside, or it can trickle into your nasopharynx, then subsequently into your oropharynx, when you call it as postnasal. This is how you, suppose early in the morning you get up, you have some foreign body sensation in the throat, you try to cough. That is one type of a postnasal discharge. Suppose you get up early in the morning and do like this. Something trickles back to your throat. That is again a postnasal discharge. So this is how you can ask the patient about a postnasal discharge. You ask him to swallow and ask whether something is coming inside your oropharynx. That can be a postnasal discharge. Sometimes the discharge can come out through the anterior nares. This is most common characteristic of a vasomotor rhinitis and an allergic rhinitis. Rarely in patient of sinusitis, the discharge comes out. Mostly in patient of allergic sinusitis, this discharge trickles back behind your nasopharynx or onto your nasopharynx and over into your oropharynx, where you call it as a postnasal discharge or a postnasal drip. Okay. So as I was speaking to you about the types of nasal discharge, it can be in the form of a serous discharge, where you will be seeing in the early stages of allergic rhinitis and non-allergic rhinitis. Serosanguinous, that is blood-stained ear discharge, which is watery in nature, characteristic of nasal septal spur. So whenever the patient is having a nasal septal spur, you can see a blood-stained nose discharge. Trauma of the nose, you can see a blood-stained nose discharge. Tumors of the nose and nasal cavity, including your paranasal sinuses, you can see a serosanguinous ear nose discharge. And any tumors involving your nose, nasopharynx can do present with a serosanguinous ear nose discharge. Mucoid nose discharge in late stages of allergic and non-allergic rhinitis. So, before I proceed, I just want to introduce you to two more terms, what we call as priming and trigger phase reactions. This priming is something where there is an initial exposure to an allergen. So, an initial exposure to an allergen causes sensitization of this goblet cells of the nasal mucosa. Nasal respiratory mucosa is ciliated columnar. So when this nasal respiratory mucosa gets sensitized to an allergen, that is what we call as priming. Priming usually will not present with an amplified clinical response. Amplified or exaggerated clinical response is not common during priming. I can't show you the pictures of priming and trigger phase reactions or pictures of allergic rhinitis because that will be difficult. These are to be theoretically understood. So when there is a second exposure to an allergen, suppose there is a second exposure to an allergen that will induce a trigger phase reaction. So during this exposure, there is an increased clinical response. There is an increased edema. There is an increased secretions of the nasal mucosa, which will, the edema itself will cause a nasal obstruction. The secretions will add up to the nasal obstruction. The secretions, if it is an early stage, that during priming, that can be a serous secretions, and during a later phase, you can see a mucoid secretions of the nasal discharge. This is quite different when it is the patient of non-allergic rhinitis or vasomotor rhinitis. Vasomotor rhinitis, because of neural stimulation, there is a continuous secretions because of the stimulation of goblet cells. Here, there is no priming is seen. The priming is absent. There is a secretions. Secretions are mucoid, and rather than mucoid, it will be a seromucoid secretion. I know this is all confusing to you. So seromucoid secretions will be characteristic of vasomotor rhinitis. Mucoid is in late phases is characteristic of rhinitis and sinusitis in late phases, and allergic rhinitis during trigger phase reactions. More of serous discharge, little of mucoid discharge is characteristic of non-allergic rhinitis or rather vasomotor rhinitis. Blood-stained nose discharge, tumors or anatomical abnormalities of the medial wall of the nose, where there can be, because of these abnormalities, there can be rubbing of the medial and lateral wall of the nose, which might be because of a nasal septal spur impinging onto your lateral wall of the nose, which can cause a blood-stained nose discharge. Suppose the patient is an elderly male, there can be blood-stained ear discharge because of a tumor involving your nasopharynx or your oropharynx or nasal cavity problem. Mucopurulent, the mucoid ear discharge with secondary infections can be because of the involvement of your paranasal sinuses, which you most commonly call as sinusitis. The sinusitis is inflammation of paranasal sinuses. There are two groups of paranasal sinuses, anterior group of paranasal sinuses, posterior group of paranasal sinuses. Anterior group of paranasal sinuses are maxillary sinus, frontal sinus, and anterior ethmoid sinus. I'm just pointing with my finger. Maxillary sinus, the tenderness is elicited over the canine fossa, lateral to your medial canthus of the nose, medial part of the nasal vestibule, medial side of the nasal vestibule. Over the canine fossa, you see tenderness over the maxillary sinus. The other groups of paranasal sinuses, palpebral and the frontal sinus, where you palpate near to your medial canthus of the eye. Then you palpate on the lateral side of the nasal bones for anterior group of ethmoid sinus. So sinusitis, which is secondarily infected, will show a mucopurulent nasal discharge. Okay. Other conditions, because of the space obstruction, most of the times the anaerobic bacteria may flare up in your paranasal sinuses, which will cause a mucopurulent nasal discharge. In my initial slides, I have been telling you that the nasal discharge in ENT in the nose is because of gram-positive and rarely gram-negative organisms only. Very rare chances that there is an anaerobic infection. So in such cases where there is a paranasal sinus obstructing tumor or late stages of rhinosinusitis with an anatomical obstruction of chronic origin or a commensals, you can suspect an anaerobic origin. Remember? Okay? And there is a surgical exploration and there is some source of infection. It has not healed. That will lead to your purulent secretions in the form of your septal abscess. This picture I will try to show in my next session. Septal abscess, where you will be seeing a secretions of your, there is a bulging of your nasal septum. It will become bulged out. Both sides it will bulge out. Okay. So the third clinical symptom, I think, if possible, with this I will try to stop the session for today. Tomorrow we will have an active, engaging session. Headache can present anywhere in your head, right? In front of your head, it can be on your head, it can be behind your head. So behind your head, you can suspect some stress-related disease conditions. On your head, something of a vascular origin you can suspect involving your cranium. Headache which presents, or rather it should be renamed as a facial pain, which presents in front, that is related to your nose. It depends on the time of presentation of headache, origin of headache, duration of headache, and sometimes you can differentiate the pain also. The area of headache is the most. Suppose you have a pain over your cheeks. There are two causes. One is your maxillary sinus headache. Second, other cause can be your trigeminal neuralgia or tic douloureux over your maxillary or your cheeks. Suppose you are having a pain here, you can say that the pain originates because of your frontal sinus. Suppose you have an eye strain, or you feel that your eyes are being pulled with pain besides your nasal bones, then you can suspect involvement of your ethmoid group of sinuses. Suppose the headache is such that it is not allowing you to open your eyes. If you open your eyes are bulging, you are experiencing like these sensations, and you are having a difficulty in opening your eyes. You can expect involvement of your sphenoid sinus. So remember, sphenoid sinus, you will not be allowed to open your eyes, or rather the disease will not allow you to open your eyes and do work. Eye strain is characteristic. Eye strain with headache of eyes, around the eyes. Around the eyes, headache is characteristic of your ethmoid sinus or ethmoid sinus. Pain over your cheek, thick dolorox, maxillary sinusitis, frontal sinusitis, pain over the frontal view. So based on the duration, it can be an early morning headache, because of which, because then we call it might be a frontal headache. Why? Because I will make you to understand, or I have to deal in my subsequent slides. One important term, osteomial complex. Remember, osteomial complex is the area where all the openings of the sinuses, especially the anterior group of sinuses, open into the osteomial complex. So this is the area of most importance, where anterior group of paranasal sinuses involved, open. So during those openings, the opening of the frontal sinus is here, and it tracks down through a small tract into your nasal cavity, into your osteomial complex. That tract is vertical. The frontal sinus is horizontal. The vertical tract is a frontal sinus. So this vertical tract has an opening at the bottom. So this opening is again vertical. So this will be opening like this, like your opening of the nasal cavity. There is one more opening here somewhere, where the frontal sinus also opens in a similar fashion. Suppose you are lying down. You are lying down like this. This opening, which is like this, your nasal, like your nasal cavity, that has turned against the gravity. You can see that has turned against the gravity to one side. It has opened like this. Previously, it was like this. As per the gravity, the secretions of the frontal sinus are draining outside freely. You are sleeping. You are lying on the bed. You are lying tossed to one side or the other. There is fluid collection in your frontal sinus that cannot come out through this opening because it is against the gravity. It has come like this. So during those times, there is all a chance for you to experience an early morning headache because of the collection of fluid in your frontal sinus. So early morning headache is characteristic of frontal sinus. Similarly, there is one more opening for your maxillary sinus. Your nasal cavity is like this. Your maxillary sinus opening is like this. Because the frontal sinus is high above, it opens like this. Your maxillary sinus opening is like this. It is perpendicular to your nasal cavity. This is opening of your nasal cavity. The opening of maxillary sinus is perpendicular to your nasal cavity and also perpendicular to your frontal sinus. So that's why whenever you are standing, suppose this is your maxillary sinus. Think that this is your maxillary sinus somewhere here. The opening of the maxillary sinus is against the gravity. So you are standing or sitting. There is a fluid collection in the maxillary sinus. In a patient with maxillary sinusitis, not in all the normal patients, not in all the normal individuals. Okay? So there is accumulation of fluid against the gravity. The patient is standing. So there is a collection of fluid. So then you can suspect that there is maxillary sinusitis. Okay. Suppose you are sleeping. Suppose you have got a right maxillary sinusitis. You are sleeping. You are sleeping to your by bending your head to your left. You are sleeping on your left ear. The opening of the right maxillary sinus has come in line with the gravity. It has come in line with the gravity. So the secretions of these maxillary sinus will trickle outside. So then the headache gets relieved. As long as you are doing work, as long as you are standing, then you are having a maxillary sinusitis. Then you can say the secretions will not come out or drain out. Then the patient will have a evening headache. Suppose there is a space occupying lesion. There is a space occupying lesion in your nasal cavity proper, which is causing a pressure symptom. Suppose it's your nasal cavity proper. This is a space occupying lesion. This has caused pressure symptoms. Then that can lead to a persistent headache. And this headache during your vascular headaches or migraine headaches, there can be a shooting type of pain also. I told you retroorbital pain is characteristic of sphenoid sinusitis. Pain between the eyes is characteristic of ethmoid sinusitis.